Today's topic is actually going to be hospice and palliative care in the long-term care setting. And I guess the first place to start is I didn't put a slide on it, but disclosures. I don't have any financial disclosures. I volunteered to come and give this talk today. And as Terry said, I work for Delaware Hospice. I've been working in the field of hospice and palliative care for some years, so it's close to my heart. And I'm actually glad to be here. It's nice to
It's nice
be
to be
in the same
in the
virtual
same
room
virtual.
with like-minded people who are interested in the same things. So goals and objectives for today. I figured if we were going to walk this journey and talk about this topic, I was first going to start with why are we choosing this topic? What are the current rates of patients living in long-term care facilities in the United States, and what do we anticipate in the coming years? So I'm going to go over some statistics on that. Then secondly, we're going to venture into what are the reasons we should be involved with these patients and help care for them? Where are the gaps in care that's currently being provided throughout the US? And then we're going to get into some of the nitty-gritty details about actual palliative medicine and hospice care being delivered in different care settings. What are challenges? What are benefits? And how do we navigate both of those? So overall, if I was to have one main takeaway, it's a better understanding of the barriers to quality end of life care as patients advance through the continuum of care. So statistics. Um, yeah, I actually pulled this right off the Population Reference Bureau as to what were their most updated things. The baby boomer generation, 1946, 1964. If you just think about that in general, unprecedented time in history. There's never been a time of more babies being born in the United States. From that, they anticipate that, in 2022, they actually identified that 58 million Americans were age 65 or older. By the year 2050, based upon what birth rates have been in the US, they anticipate that number to escalate to about 82 million Americans. So to just put that into context and think wholeheartedly about it, that means that 1 in 6 Americans are age 65 and older. Um, if you ever spend some time rummaging through the CDC's website, they do biannual, annual, they have reports on almost anything. I actually had to go back to 2020 for this because it was right before the pandemic when they actually released their full detailed biannual report. I tried finding more information about it since then. There's details, but no great specifics. So I did have to go back to that one for this slide. But looking at nursing homes in the United States, they calculate there was 15,300 nursing homes back in 2020. About 1.6 million licenses beds were available for patients. At the time, 1.3 million residents were residing in those facilities. Some important details are over 2 million patients actually received care and were discharged from services. So just thinking roughly over 365 days, it's a fair amount of people. During that time period, 1,534,000 patients actually received hospice services. So thinking globally just about the number of patients that are going to be passing through these facilities, that number is pretty astronomical. So something that I thought would be important to add here, and okay, we're talking about a large number of elderly patients in the United States. If you actually think about when a patient enters into a nursing home, what does that mean for their quality of life? And what does that also mean for their overall life expectancy? If you've ever spent any time on the website ePrognosis or looking at prognostic indicators, the questions are always going to be asked about, does this patient need help with activities of daily living? Are they declining from a functionality standpoint? What's their ECOG score? What's their Karnofsky performance score? What's their PPS? We're looking at functionality as a predictor of mortality for patients as being a big predictor. So if you think about the idea of a patient transitioning through the continuum of care, independent living, assisted living, then needing a full SNF level of care or long-term care facility, those are all because of assistance with ADLs and functionality. So some smart people went through, they did a study over a 3-year period, and they actually followed some nursing home residents. There's almost 700 of them on this study. They looked at how long did these patients live after they made this transition of care from entering this facility till the time they died. And the median survival that they found out was somewhere around 2.2 years, which if you actually do the math on that, the yearly mortality rate was observed as being about 31.8%, which means 1 in 3 patients entering that facility was dying per year. They did make some correlations with that of what were the associations with mortality rate for those patients. So needing a higher assistance with ADL dependency, having a lower BMI, having a higher age, even though we shouldn't discriminate against that, the number of comorbidities at baseline when that patient actually entered the facility was significant. And for dementia patients, the severity of the patient's dementia that was actually being documented. Now, I'm sure just seeing who's on this call today that many of you have read this article. If not, I could actually email it out after we're done talking, just so everybody has it. But it's a really interesting publication. It's actually written by some smart people out in California. One of them is actually a very well-known palliative medicine provider out there. It's called Rehab to Death. It was a 2019 publication, New England Journal of Medicine, where a bunch of providers got together and they wanted to write about what is the issue that we have through the medical system we have set up and how insurances pay for these services, talking about the 100 rehab days that Medicare would pay for many of these patients for their skilled services. Talking about the transition of now this person has transitioned into a long-term care facility, then they end up in the hospital, then we kick them back to the facility to get some form of rehab. They end up back in the hospital, they go back to the facility, and then they reach the end of their life. And what are we doing for these patients? How are we navigating those goals of care conversations? Are they having those conversations? And what is actually happening? Does the patient understand what this means for the significance of their life expectancy? At the end of the article, they actually get into some of the details talking about legislative policy making surrounding what the political parties are doing for Medicare and how this kind of contributes to how we care for people in the United States during that time period. So I'll actually send that out to Terry and Dr. Matthews and such, that way they could email it out when we're done. Now, the big question is, why are we needed? Why is hospice needed? Why is palliative care needed? So now be ready. I put a bunch of studies on here to give you some evidence-based approaches on a lot of different aspects of stuff. So a national survey, this one was very interesting, I thought. A national survey of bereaved family caregivers of nursing home residents. So a patient lived in a nursing home, passes away. They then surveyed the patient's family and caregiver to try to get a better understanding of what their experience was like. Almost 1 in 4 caregivers said that the patients experienced pain or dyspnea and did not receive any support for it. About 60% reported receiving inadequate emotional support during their loved one's terminal illness. And about 42% of them rated their loved one's quality of life in the nursing home as excellent, while in contrast, 71% rated the care delivered at home with hospice services as excellent. So where are we missing, or where are the gaps in this patient's care, and where can we fit in to help them? So I was I was going through a national survey of bereaved family caregivers that was looking at um, patients had resided in a nursing facility. They passed away. So they actually surveyed the caregiver to get an idea of what was the experience of the loved one. And almost a quarter of them actually said that the patients that were residing in the facility experienced pain or dyspnea and didn't receive any treatment for it or support. Almost about 2/3 of them reported receiving inadequate emotional support during their loved one's terminal illness. Additionally, about 42% of caregivers rated their loved one's quality of life in the nursing home as excellent, whereas in contrast, about 71% related the care delivered at home with hospice services as excellent. So there's definitely a gap in the care of what we're providing for patients in this setting. So with that, I figured it would be important to talk about some studies on what are the actual interventions and symptoms that we've identified and how do us as providers be able to support these patients. So in 2017, there was a pain and pharmacologic pain management in long-stay nursing home residents article, and that demonstrated that about 1 in 3 patients of a long-term care facility actually experienced persistent or intermittent pain during a 3-month period that they were just looking overall at patient satisfaction and quality scores. Care settings and clinical characteristics of older adults, specifically with some form of dementia back in 2019, actually had that 59% of long-term care residents with moderately severe dementia were affected by pain, and 40% of them had activity limitation in relation to uncontrolled pain. Another study, hold on, let me move my screen because I can't see it all. In 2017, looking at the frequency and predictors of analgesic prescribing in United States nursing home residents with persistent pain, only about 6.4% of long-term care residents report untreated pain, which I actually thought was good in my mind. The bad aspect of what this study identified is almost about 1 in 3 of those residents whose pain was being actively treated reported it was undertreated. And when I actually looked through some of the details of that study in particular, it did bring up cancer-related pain as being one of the symptoms that those patients were experiencing. Looking at additional things we can help out with. So dyspnea, approximately 50% of dying patients in long-term care facilities actually experience dyspnea. Oral intake, nutritional issues, unintentional weight loss. I'm sure many people on this call today have had discussions about this with patients day in and day out. Very common complaint. So this study actually showed that over 70% of long-term care residents experience one of these 3 symptoms. And that includes lack of appetite, dysphagia, xerostomia, dental problems. And the list just kind of goes on and on when you start to think about that category of symptoms. Neurocognitive symptoms. This is something that comes up all the time, especially with patients dealing with either intracranial metastatic disease or some form of dementia. At end of life, cumulative instance of delirium has been found to be as high as 85% in one study. It is a little bit older, but looking at patients residing in facilities, that's pretty high. Now, I figured after talking about a boatload of studies and what they actually show from an evidence-based perspective, I've personally seen patients in nursing homes. I've seen them in facilities on top of when they go in the hospital. I'm seeing them from a palliative care perspective. And I figured I'd just give you some of my personal thoughts on a lot of things that reverberate what a lot of these studies actually show. Long-term care facilities, if you just think about how they're set up and what they're doing, their primary goal at times is rehabilitative or skilled care for patients. So that's what they're good at, and that's what they're going to focus on for the most part. They're not set up to be hospice facilities. And we're going to talk more about where some of the care gaps are. And I could tell you personally on top of, what the challenges are that we deal with on a day-to-day basis. Lack of education, comfort level, and caring for patients at the end of their life. Probably one of the top things in my mind that ends up coming up through discussions. Gaps in inappropriate goals of care conversations. I should have probably wrote inappropriate goals of care conversations because they aren't held at times. You have that patient, and this kind of goes back to that rehab to death article I talked about briefly. You have that patient that's going back and forth from the hospital to their long-term care facility. They're being rehabbed for whatever disease process they're dealing with. But have we sat down and talked with them if they are cognitively intact or their family or loved ones about what's actually going on, what we're worried about, how much they've been declining? Staff turnover, especially ever since the pandemic happened. I mean, that's been a huge issue for facilities and hospitals and acute care settings everywhere. And then, still we have the societal stigma around the words hospice, around the words palliative care. What is that? What does that mean for a patient or loved one? I think overall, the pandemic, even as horrible of a time period it was and what that meant for all of us as humans, I think that did help to broaden the word palliative care and how people perceive it, what that means from it being used in society much more. But I still think there's a lot of ways to go with it. Now, from that, now we kind of get into what I was invited here to talk about today. I thought that if I was going to talk about long-term care settings, we need to build a foundation on why we should talk about it. So we're first going to start out with palliative medicine or palliative care. And if we're going to talk about a long-term care setting, we really have to think about how patients get there, what are the barriers, and when should we intervene, and what does it look like? So independent living or somebody living in their home or vice versa, that patient isn't receiving any additional ADL support. They're living on their own is the point of that. Assisted living and many of these facilities are going to have a stepwise pattern for the patients to receive care. Some of them that are independent living are also assisted living. Some of them that are assisted living are also long-term care centers, but they have the different levels of support to transition patients when they need that care. So I just think of it as a step up. You have the assisted living where they're getting some level of support, even if it's minimum and somebody that can ring on a call bell to come in 2 hours to come by and see them. But it's demonstrating that that patient has needed some additional support. And if you think about palliative care in a sense of seeing these patients, I always think of palliative care being able to see someone. It's going to be the same as any other specialist. If somebody's going out to see their cardiologist, they could also go to a palliative medicine appointment. So I know that one of the things that the coalition wanted me to chat about today is insurances, how that plays into all this, and how people pay for these services, and how people are seen by these different specialties. With palliative medicine, it's going to be a Medicare Part B. That's what's going to be billed by it. And coinsurance may apply for palliative care because typically there's going to be some form of copay or percentage that's not covered. But with it, it's the same as any patient going out and seeing any other provider. Now, when somebody enters a long-term care facility, it's still going to be the same. I know that that conversation is going to change when we start to get to the hospice piece of it, but just think of it as somebody seeing a specialist. Patients schedule their appointments the same as any other medical specialty. Outpatient offices, same as waiting for your 2:30 appointment this afternoon. There's also home-based services. And many times, if you actually look at studies on how these patients, especially long-term care facility patients, are seeing palliative care, many times it's going to be in the inpatient setting when they're admitted to the hospital or something acute going on. Now, with this, with palliative medicine in general, writing prescriptions for patients, just like as if they're seeing their cardiologist and getting their metoprolol, they'll be written directly to patients when they're living in independent living and assisted living. The issue tends to come up when they're actually living in a long-term care facility. The medical director of that facility is going to be the primary provider for them. I've come across this issue many times. I'm sure other people here today have also had this issue where you want to make a recommendation to improve the care of nausea, pain, dyspnea, whatever the patient's dealing with, but you write more so a recommendation and then need that recommendation be followed through by the provider at the facility who's directly writing the orders for it. So barriers for patients in the long-term care setting is, in my opinion, is probably the pharmacologic intervention is usually the hardest because you see a patient, you see what their issues are. You're the expert in the field of trying to improve their cancer-related pain symptom, but you can't physically write the prescription because everything is going to be provided by that main provider at the facility. One way to easily get over this, I've written countless notes, even my phone number on business cards, and I could tell you this still hasn't gotten through, but picking up the phone and talking directly and collaborating with that provider really makes a difference for the care of some of these patients. So coordination of care, and the other piece that we can now start to talk about is goals of care for patients. If they're living in a long-term care facility, they're being rounded on semi-regularly by the in-house provider. They're seeing all the nursing staff that are providing their day-to-day care. Many times these conversations aren't being held. And you really need to include all the care partners because many of these patients, that is their home, that is their family. Maybe they don't have many living family members, or maybe their family members are out of state. So the people over the past year or so that have gotten to know them, who they are as a person, what their personal preferences are and wishes are the actual facility staff. They should be included in these conversations. Um, the other issue that tends to come up or be a barrier for patient cares are those with cognitive impairments. You have a patient that's living in a locked dementia unit that is still ambulatory with a PPS and maybe 60% or so, but they keep repeating the same words over and over. They can't understand or comprehend a conversation with you. And they are living in a facility where family is only able to visit them once a week. Well, the primary reliable historian for that person is probably going to be the primary nurse that sees them on their 8-hour shift Monday through Friday. But staff turnover, especially ever since the pandemic, really makes getting those accurate histories, even if you talk with the facility members, pretty difficult. Now, the story does change a little bit when we start to talk about hospice care, but there's similar barriers that we'll talk about. The same three care settings, independent living, assisted living versus a long-term care setting. Patients get hospice care in any of the three, but it does look slightly different from a pharmacologic perspective, as we were talking about with palliative care. So, hospice, it is going to be billed differently. So it's a Medicare Part A benefit. Copays may apply for hospice care. A lot of people don't realize that. I could tell you with Delaware Hospice, we don't charge patients for their copays. I'm sure that many hospice agencies out there also do the same and don't charge patients, but it can be a part of it. With it, and this is important because if you think about the Medicare Part B component of palliative care, patients that are receiving palliative care, they're seeing a subspecialist, they're typically still receiving a restorative plan of care, which means they're receiving rehabilitative services. They're seeing the physical therapists, they're seeing their speech and language pathologist, they're going to the hospital to go receive chemotherapies. They want a restorative plan of care to try to rehab things of whatever the medical issue may be. With hospice care, the main portion of that is that it's a symptom or comfort-based plan of care. The restorative plan of care isn't going to make them any more functional. They've reached a point in their terminal illness where we're just focusing on symptoms. The services delivered in independent and assisted living are going to be the same as in the long-term care setting. The only barriers that we come across, that'll be on the next slide, comes into how we interact with the staff, how we recommend the pharmacologic intervention, and actually supporting those staff members as if they're family because of their role in the patient care. Now, keep in mind, long-term care facilities, they have contracts with whoever they decide to have financial contracts with. If you talk to a lot of the facilities locally, some are going to have contracts with multiple hospice agencies. Other ones may just choose one, and it's really their preference. So that is something to keep in mind because we always know that whenever a patient enters the hospital or we're having a conversation about hospice, we're giving them choices. But in long-term care facilities, they may not have that option. So barriers, the biggest thing, and I could tell you I've seen this time, year after year, time in, time out, is the lack of staff education around the dying process. What are terminal secretions? What is apnea and Cheyne-Stokes respiratory pattern? What is terminal restlessness? How do we acknowledge it? How do we identify it? What are the nonverbal signs of pain? If somebody can't speak to you and tell you that their pain is a 9 out of 10 because they're imminently dying, how do you assess that? And I was talking to some of the staff members on my Dover team recently, and they're doing education at one of the local nursing homes just on what are the signs and symptoms of an imminently dying patient, and how do we treat it, and how do we care for it and comfort them. Um, with it, delay in medication administration. This is a big issue that tends to come up. I know I've talked with countless staff and facilities about this, even in my short time being here at Delaware Hospice, of, okay, you have a medical director, maybe they are overseeing multiple facilities and on call for one after hours, and there's a patient that's developing some I don't know, some dyspnea and their respiratory rates in the 30s. The staff in the facility say, "Oh, we can give morphine to them," and they give us a call out because they're worried about, the symptoms that that patient's experiencing. We give a recommendation of here's the Roxanol dose, here's how often to give it, put a fan in their face and talk through all of those things. But that order still has to come from the facility provider. And so we communicate one way, that another communication has to happen. They have to agree with it and then write the order for it. It could be a large delay between the time period from when we first talk with them until a patient actually receives medication, if they even get it. And something that always comes up is the room and board fee associated with the pursuit of hospice in a long-term care setting. I mean, to put it bluntly, nursing homes are expensive. If you don't know how much they cost, ask anyone. They cost upwards of tens of thousands of dollars per month, which is incredible. And that's always been an ongoing topic of, with the hospice benefit, how do we care for these people and how do we afford things like this? So with it, if you think about the benefits of hospice and palliative care in any of these settings, and we've talked a lot already about symptoms and the aging population and so on and so forth, effective communication with staff and care teams around patients' goals can work wonders from a wide variety of perspectives. When you actually ask somebody what's important to them and they haven't wanted to go back to the hospital for God knows how long, I mean, that right there can lead to so much empowerment for the patient, doing a demos form with them, making sure their wishes are being honored and caring for them the way that they want to be cared for. And I can't tell you how many patients have told me over the years that the last thing they would want to do is die in the hospital. I mean, I hear vice versa from some people because that's what their personal preferences and goals are. But when you hear that somebody's goal is that they don't want to die in a healthcare setting, specifically an acute care setting, there's ways that we can put their wishes on paper in many perspectives to help avoid those unnecessary hospitalizations when that time comes. Um, Longitudinal grief support after a patient passes is a huge benefit, especially in the hospice realm. If a patient enrolls in hospice and passes away, their family and loved ones are entitled to 13 months of bereavement support following the passing, and even longer in some instances after the passing of that individual. In facilities itself, many times the family is the actual staff in the facility. And our team is actively involved with how do we engage with those people? How do we provide them support, knowing that those were the ones that knew the patient best? They were the ones that cared for them for years and sometimes even longer. And being able to be there as an extra layer of support for them. And the biggest one in my mind is just the evidence-based approach to end-of-life care from actual board certified specialists in the field. I mean, there are so many conversations that if we begin talking about a medication or topic, I could probably talk your off about some, blurb I already have in my mind from the thousand other times I've already talked about it, about, morphine not causing somebody to reach the end of their life faster and so on and so forth. So with all of that, what are some take-home points? We talked about a lot before I got cut off, and hopefully I picked up at a okay place when I was getting back on here. But I hope takeaways from all this is that the elderly population in the US is going to significantly rise in the coming years in the next 2 decades. And that is going to be an issue that all of us in healthcare are going to be facing. Long-term care facilities tend to have a high mortality rate. So, I mean, I posted a few studies on here, but just keep in mind that change in level of care is associated with a change in prognosis for that patient and what it actually looks like. Evidence-based care delivered in the facilities can definitely be improved from multiple aspects. I mean, I put a boatload of studies on those few slides just to give you examples of things of what we're good at and what is being missed for patients as they have a terminal illness in a facility. Early integration of palliative medicine services can be crucial to delivering patient-centered care. I mean, if you go on any organizational website, look at any studies that are out there about the models of when should you consult a palliative medicine provider? When is the terminal illness diagnosed? They have a serious medical illness change that begins to affect their quality of life. When that effect happens, that is the time they should start to have a discussion with somebody. Even if their prognosis is years or even longer, you start that conversation, you have touch points, and you build that relationship over time. Um, Hospice involvement with end of life care for long term care patients can provide better quality of care, not only for the residents, but also for their loved ones and caregivers. A bunch of references here.